I think it's clear that the nation is concerned about the opioid abuse epidemic, particularly the prescription epidemic. And I think although it hasn't quite had the impact in patients with cancer as it has perhaps in patients with chronic pain who don't have cancer, I think still we're being impacted by the continued abuse of opioids, misuse of opioids, and I think clinicians are finding it more challenging to manage these patients, particularly those who have a complex combination of issues. They have cancer-related pain, they have perhaps an underlying pre-existing chronic pain disorder, they may have pain related to therapy such as neuropathic pain, and then you add a potential for addiction or substance use disorder or inappropriate use of opioids, and you've got a major challenge, clinical challenge, that oncologists have to deal with. I think the key for the clinician is to identify those patients who are in need of a specialized treatment. And by specialized treatment, I mean either referral to a specialist palliative care team or perhaps a specialist pain team. And the way to do that is to perform screening procedures, screening of past opioid misuse, past history of alcoholism, and that can be fairly simply done with things like a CAGE score. So a CAGE score is a 4-item score that screens for alcoholism. Patients with a history of alcoholism are typically predisposed to opioid misuse also. I think there's not a lot of evidence, but there are at least 3 studies that suggest patients may be abusing opioids and they may even be diverting opioids. So there are urine drug test studies that suggest that maybe up to a third of patients don't have the prescribed opioids. The data linking patients with cancer to opioid abuse, there are several studies. We'll start with the screening tools. 1 in 5 patients are identified with those screening tools I mentioned, the CAGE score or the opioid risk tool, are identified as being at high risk for opioid misuse. Right, so 1 in 5. Then as far as urine drug testing is concerned, there are 3 studies of urine drug tests in patients being treated for cancer, active cancer, that suggest somewhere between 20% and a third have abnormal urine drug tests. So either they don't have the opioid that's being prescribed in their urine, or if they do have the opioid prescribed in the urine, they have other non-prescribed opioids and even street drugs. So that's a pretty high percentage and mirrors that of patients who've been treated for chronic non-cancer related pain.
One of the things that has changed in the last few years is the number of drugs that we need to test for in our comprehensive urine testing. Several years ago, we only tested for prescription opioids. Now we find ourselves testing for a wide variety of prescription and illicit opioids, as well as other illicit substances. We've expanded our panel now to 55 drugs. We also offer a lot of non-opioid options for cancer-related pain. There are multiple categories of drugs, anti-epileptic drugs and antidepressants that are very efficacious for cancer and cancer-related pain. We have a pain agreement that the patient signs that shows them specifically the steps that they have to follow for us to continue to prescribe safely and legally the opioids that they need for their pain control. We also now include an informed consent, which describes the risks of opioid therapy, especially in the long term, which includes dependence and addiction. We've done well to identify the patients that develop addiction and direct them to substance abuse treatment programs. And as long as they are compliant and enrolled in the program, we continue to prescribe, and they have done well. Overall, in the current opioid crisis, we have come to recognize that opioids, while important and critical for treating pain in cancer patients, it is not the sum total of their care. Additionally, we are now identifying more risks that are associated with opioid therapy and treating them appropriately. It's important to understand that it takes 2 people to develop an addiction to prescribed opioids. It takes someone to take the opioids and another to prescribe them. So this has created an environment of shared responsibility that we take very seriously.